Hello everyone, my name is Noor Al-Huda and today I'd like to share a short teaching session titled Every Question Has a Purpose, Thinking Through Chest Pain History. By the end of this session, you should be able to explain how selected history questions influence your differential diagnosis in a patient presenting with acute chest pain. Let's begin with an important idea. Many medical students learn history taking as a checklist of questions, but experienced clinicians don't ask questions simply because they are on a checklist. No, they ask them because every answer shapes their clinical thinking. So today, I will not teach you what questions to ask. Instead, I'll show you why each question matters and how every answer helps refine your differential diagnosis. So, let's apply this to a clinical case. In this case, we have a 36-year-old patient presents to the emergency department with acute chest pain. Before asking any questions, pause for a moment. What diagnoses come to your mind? Normally, at this stage, every diagnosis in your mind is still a possibility. So, how do we begin to narrow our differential diagnosis? Simply by asking some questions. The first question I'd ask the patient is, can you describe your pain? The patient replies, it's a sharp pain. Okay, so why is this question important? It's important because the character of chest pain is often the first clue that helps distinguish ischemic pain from a pleuritic or inflammatory pain. So this answer shifts my thinking toward pleuritic and inflammatory causes like pleurisy, pneumothorax, pulmonary embolism, and acute pericarditis, while ischemic causes like acute coronary syndrome become less likely, although it's with less significant change on gastroesophageal reflux disease as shown in the table. Notice that I'm not making a diagnosis yet. I'm simply updating my differential diagnosis based on one new piece of information at a time. My next question is, does the pain radiate anywhere? The patient says, yes, it radiates to my left shoulder. Now we have got another clue. So before we look at the table, how do you think this answer changes our differential diagnosis now? Radiation to the shoulder, particularly the trapezius region, increases the likelihood of acute pericarditis while making several other diagnoses less likely. Notice that some diagnoses remain unchanged. That's because not every answer affects every diagnosis equally, okay? Some answers increase the likelihood of certain conditions, decrease the likelihood of others, and leave some unchanged. That's why we need to keep asking more questions, more purposeful questions. So, the next question will be, does anything make the pain better or worse? The patient replies, it gets worse when I take a deep breath or lie flat, and it improves when I sit up and lean forward. So, why do you think is this question so valuable? Because aggravating and relieving factors often reveal characteristic clinical pattern. And this pattern strongly supports acute pericarditis as shown in the table, while making other diagnoses less likely like pulmonary embolism, pleurisy, and pneumothorax. So, acute pericarditis now has become our leading diagnosis. Now let's look back at the case and see how our thinking has evolved. At the beginning, every diagnosis was equally possible, okay? Then each answer narrowed our differential diagnosis. And now, based on the history alone, acute pericarditis has become our leading diagnosis. And as you notice, we didn't reach this conclusion because of one answer. No, we reached it because we connected several clues together. This way of thinking doesn't apply only to chest pain. Whether your patient presents with abdominal pain, headache, shortness of a breath, or any other symptom, the principle is exactly the same. Every history question should have a purpose. Every answer should move your thinking one step closer to the most likely diagnosis. Now it's your turn. Let's see if you can apply the same thinking process yourself. Your patient is a 62-year-old man who presents with acute chest pain. When you ask him about the character of the pain, he says, "The pain is heavy." How does this answer change your differential diagnosis? When the patient says, "The pain radiates to the left arm," how has your thinking changed now? The patient continued, "It starts during exertion and improves with rest." Based on all this information you have gathered, what's now your leading diagnosis? If you thought of acute coronary syndrome after making each answer lead you to a new information and new possibilities, you now understand how to do clinical reasoning without jumping directly to the diagnosis, of course. And the take-home message from this session is, don't ask questions because they are written on a checklist. Ask them because every question has a purpose, every answer is a clue, and every clue refines your differential diagnosis. You must think during you collect a history information. Don't just take it. And if every question changes the way you think, then you have already started thinking like a clinician. Thank you for your attention. I wish you a very successful life in your medical journey, and I hope that from today onward, every question you ask has a purpose.